So, good evening, everyone. Welcome to the session. Sorry to keep you waiting a little bit. Today is World Schizophrenia Day, and schizophrenia is a serious mental illness that affects roughly 24 million people worldwide. I just checked on the internet. It could be 1 or 2 million more than that. And in India, the figure is about 5 million, plus or minus 10-15%. The objective of this day is to shed some light on mental illness, schizophrenia, increase the awareness, reduce the stigma and discrimination, and the myths surrounding mental illness. Before we start, a little bit about the two host organizations, Pushpanjali Trust and Sambandh Health Foundation. Pushpanjali Trust is a charitable trust based in Chandigarh. We work on awareness and we've been working since the last 7 years. I request Deepshikha from Sambandh Health Foundation, Gurgaon, to tell us a little bit about Sambandh Health Foundation. Deepshikha.
Good evening, everyone. My name is Deepshikha. I am from Sambandh Health Foundation. I'm the director of the programs here. Sambandh Health Foundation is a public charitable trust working in the field of mental health. For over 14 years, we have supported individuals living with mental illness and their families across Gurgaon city and semi-urban areas through a community development approach. We work in collaboration with Government of Haryana and District Mental Health Team. So far, we have directly engaged with over 5,000 individuals and sensitized more than 1 lakh people to reduce stigma and promote inclusion. At Sambandh, we believe that recovery is possible and our focus on strengths, not deficits, and we believe on building inclusive communities that offer dignity, opportunity, and hope. We operate through a community development lens, educating and empowering communities to overcome stigma. Influence positive change at individuals at the community level. We work with the individuals with mental illness. We work with families and offering support through family self-help groups and individual counseling. We also work with communities creating awareness, building inclusive environment to education, and engaged with various schools, health institution. I request Dr. Aditya to take on this.
Dr. Aditya, hold on, I have to introduce you. We had worked it with Deepshikha that she will put it back to me, but I think she's in a hurry that Dr. Aditya starts the presentation. So, schizophrenia is a serious mental illness, and the idea of this day is to shed awareness because there is still a lot of ignorance in our society. And what we do at Pushpanjali Trust, and this time we decided to partner with Sambandh Health Foundation, what we do is, especially on this day, we invite a speaker of eminence, we invite a distinguished speaker and a distinguished professional to kindly, tell us about schizophrenia, where the treatment and recovery processes is headed, what are the latest discoveries, and what is the hope for patients and families struggling with schizophrenia.
Aditya, your
voice was breaking.
Yeah.
I am so sorry. I deeply apologize. Somehow today, some Wi-Fi issues. I will try to sort them out. I've been working on it for the last half an hour, but I just, fingers crossed, I hope it doesn't happen again. So without further ado, I introduce our illustrious speaker today. Dr. Aditya is the medical director of Manasa Neuropsychiatric Hospital in Bangalore. and CEO of Richmond Fellowship Society, Bangalore. He is a fellow of the Royal College of Psychiatrists, UK, and a consultant liaison psychiatrist in the NHS, UK. He completed his postgraduate training in psychiatry in Edinburgh, UK, and went on to specialize in neuropsychiatry and liaison psychiatry. In 2023, he was awarded a doctorate in medicine by the University of Edinburgh, UK, for his research on the psychosocial effects of cosmetic surgery. How on earth did you think of doing this, Dr. Aditya? I hope sometime later you will shed some light on this. Dr. Aditya is a Scottish improvement leader with an interest in improving the quality of mental health care. He is actively involved in teaching and training. He has set up one of India's first online internship programs for psychology and teaches an online master's course for psychiatry in the UK. So that's our distinguished speaker for the day. Over to you, Dr. Aditya. Once Dr. Aditya finishes the presentation, we'll have an interactive question and answer session. You can, in the meanwhile, type your questions, any clarificatory questions or anything in either the chat box, or there's also a question box. And then I and Deepshikha will take the questions. We'll pass on the questions to Dr. Aditya once his presentation is over. Over to you, Dr. Aditya.
It is.
Can you see them?
Yes. Yes.
Okay, let me know if they're not moving, because that sometimes
Sure.
happens. And I'm very grateful to the Sambandh Trust and Pushpanjali Trust for inviting me to this on World Schizophrenia Day. I feel like a bit of an outsider in schizophrenia after all these years, and I'll explain why. And I've been told that I should speak for no more than 25 minutes or so that we can have lots of conversation. But I will not ado, I'm going to see if I can move my slides. Okay. Deepshikha, did my slide move? Can you see it? Okay, so I work with several organizations. Psychiatric hospital, we do a lot of acute psychiatry, and it's where I learned quite a lot of my psychiatry. And the other place I work with, I'm CEO of Richmond Fellowship Society, Bangalore. And over there, we provide lots of long-term care and short-term care for people with severe and enduring mental illness, mostly schizophrenia, but fairly recently also intellectual disability. And we'll talk about that in a minute. I've been trained in the UK, and I've studied at the University of Edinburgh. I've taught at the University of Edinburgh. I'm also a fellow of the Royal College, and I have worked for the Scottish Government as well. Okay, so now, Aditya, and I apologize in advance for the one photograph I could find on the internet. Aditya asked me to talk about what schizophrenia is because he said there may be people in the audience who are not wholly familiar with this. So I apologize to those of you who are experts in this subject, either by experience or by profession, but I'm going to try and give you a very personal account of it. I thought I was going to focus on how I actually explain it to my patients and their families in my clinic, rather than a usual technical talk. And those of you who think I am over-summarizing, over-generalizing, or being frankly incorrect, please raise your hands and shout at me and we can discuss it. So what is schizophrenia? It's a heritable, so something that you can inherit, chronic brain disease that is associated with a lot of symptom clusters and deficits that I will go on to talk about. To us, it's a very serious brain condition, and I think it has taken me a while to call it a disease as opposed to a disorder, and I will explain why. Who gets it? 1 in 100, as I say to my families. And certainly it seems that slightly more men than women get it. So in this family of 3, or the 3 men to every 2 women, but that might be wrong. It might just be who's presenting. but certainly more men. And men seem to get it earlier, about 5 years earlier than women. Between 18 and 25 is what we say is the peak onset, age of onset, but 25% have it after 35 and a very small number after 75. What causes it? We call it a neurodevelopmental disorder, and we'll talk about what might cause it. But in the same way as autism presents early. In schizophrenia, it seems to present late, and there are reasons for it. And the reasons might be, I'll talk about that too. All my patients' families ask me this question: why me? Why her? Why him? Whoever it is that has the illness. And these are the things I say to all of my patients and their families, because I believe it. So far, we don't think there has been a way to prevent it unless it has been caused by something absolutely clear. Most of the causes of schizophrenia are fairly obscure and certainly not obviously preventable. I use this phrase and I say, look, in English, we say the cause is genetic. So it may have been programmed into you well before your birth. And therefore, it's neither your fault nor your parents nor anyone else. If you're speaking Kannada, I might say, if you want to think of it as vidhi, then that's something else, which is fate. And if you're speaking Hindi, Urdu, nasib or takdir, these are complex words though, and I think they're very closely attached to words like karma, and I don't want to attach them to words like karma because I don't think these are things being visited upon you for past sins. So I do make as far as possible, as clear as possible that I don't think my poor patient is caused it in some way, nor has their family. It's important for us to do that because I want to say that psychiatry 50 years ago did suggest that mothers were responsible for schizophrenia. And a lot of mothers for many years suffered enormous guilt because of terms like the schizophrenogenic mother. Things that we have now felt were absolutely unfair. In the same way, in autism, we used to think autism was a consequence of bad parenting and poor mothers got it in the neck, but we don't think that again. So technically, we're meant to say there are 3 clusters of symptoms: positive symptoms, negative, cognitive. I say to all my families, positive symptoms are those things that should not be in each of us, but is there in your loved one. Negative symptoms are those features and strengths that should be in us that are missing in someone with schizophrenia. And then there is this group called cognitive symptoms, and we'll talk about those too. Positive symptoms include things like delusions, hallucinations, thought disorders. So these are things that shouldn't be there. And delusions are fixed, firm, false beliefs that are out of keeping with someone's social and occupational and cultural background. Negative symptoms are those things that really should be in all of us, like ambition, motivation, ability to plan, sequence, but become mysteriously missing in many of my patients with schizophrenia. And unfortunately, I think predict more disability than the positive symptoms. Most of us get very focused on the positive symptoms because those look abnormal. But what is missing may cause my patients much more trouble than what is there. Cognitive symptoms may underlie some of these negative symptoms. These are problems with thinking, these are problems with problem solving, and these are problems with attention and concentration, and frankly, memory. So many of my patients say, I'm not as bright as I used to be. And there may be, as long ago was suggested, there may be a drop in overall performance IQ in some of my patients. In truth, there are many clusters of symptoms in schizophrenia. It's not just 3. We think that mood is also clearly affected in the majority of our patients. Movement is also abnormal. Movement usually is subsumed under positive symptoms, but I was looking this week, one of my patients has very interesting movement as part of her illness. She does this, and it's very interesting. She has catatonic symptoms. And these are very easily missed if you're not looking for them. But movement disorder is part of schizophrenia, has been for a long time, and we forget it at our patients' peril. How do we treat it? If you look at any information pack, it says medication, low-dose medication. That thing on the top left is dopamine. Blocking dopamine receptors, different dopamine receptors, is what most of our medications do. And they do help in that way, but not without side effects. In the middle, you'll see Mrs. Janaki Aital, who's an excellent psychologist working with us. And sometimes you will do psychoeducation. If the psychiatrist doesn't have the time or the ability to do it, then a good psychologist will do it. But right at the outset, in the acute phase of the illness, education is the most important psychological intervention you can do. on the top right and the bottom right, you'll see that some of my patients will need rehabilitation as well. But on the bottom left, what you'll see is our hospital in Bangalore, the White Building. And occasionally some of my patients are so ill or so at risk, either from distress or self-neglect or not eating and drinking or catatonia, not moving, or suicidal thoughts or violent thoughts, that some of my patients will need to be admitted to a psychiatric hospital, at least for a little while. And once they're better, they may need rehabilitation, either in terms of daycare. The red building you see is Chetana, our daycare unit, and the building below it is our halfway home. And the lady in the center is Dr. Lata Hemchand, probably one of the only psychologists I know anywhere in the world who has the kind of experience you'd want from a psychologist working with people with schizophrenia, so that she does not. So she works safely with them and is able to work with them even when they have comorbidity, and has the experience. Very few people in the world, very few psychologists in the world have that kind of experience. I'm very grateful to work with her. Forgive me if I'm boring those of you who are already aware of it. It's hard to know what happens when we first see schizophrenia. We think by the time we see what the Americans call a psychotic break, which is the hallucinations, delusions, and the frank abnormal behaviors and thoughts, that people may have actually had the illness for quite a while, and they may have started falling off socially. They may become socially isolated first. They may be failing their exams. They may be struggling with their college course or their work. And then we'll see what the Americans call a prodrome in the green light that you can see here. The first green line is the first psychotic illness. Why the disability tracks like that is that it may be that the first episode is not associated with a lot of disability, but subsequent episodes, there used to be a term that each episode comes with what is called progressive deficit. And I'll talk about this. One of my teachers and mentors, Dr. Kalyan Sundaram, uses the word brain damage. It's a very strong word, but over the years, I've come to see that he is right. And although it scares many families to hear it right at the outset, that is possibly what is happening. What you will see is that the disability tracks, and as you look at the orange line with negative symptoms, it actually increases in some of my patients, even though the cognitive symptoms, the thinking abilities don't change after the first trouble. The negative symptoms predict a lot more disability than anything else. The positive symptoms settle down, especially if you get the treatment right, and they don't cause real trouble in the old age. It's the negative symptoms that seem to cause us most trouble. But different strokes for different people. A small number of people have a single episode and never have another illness, but most people will either have recurrences or a continuous relapsing or fluctuating course. There are things I say to all my families I'm going to say to you. I tell all my patients, they'll say, you know how when you're in real distress, you will say things, doctors, that saying, you're the only one who can help me. And my job is to lower their expectations, say, look, I'm like a mechanic. I'll do the treatment. If you're religious, you do the dua. And that I think is important, because as an atheist and agnostic, I really don't have much understanding of God or the spirituality, but all my patients seem to have it. And I think it's important that if that is what gives them comfort, that they apply to their family God for some recovery while I do my work. And I think the Dawa and Dua programs that have been set up in different parts of India are fantastic. I always tell my patients and families, there are two things not in my control: how quickly you'll get better and how fully you will get better. That's definitely not under my control. If you're religious and you believe God is in control, then so be it. But I'm certainly not in control of those things. Two things to remember: it is an illness. And the irony is, when my patients first arrive, the majority of them will never agree that it's an illness. At best, what we will agree is that there is suffering. So I might have to say to them, it's okay if you don't believe me. You don't need to believe that the treatment is going to help you in order for it to help. I think the treatment will help you. Give me 3 months and we'll see where we get. And in fairness to most of my patients, and I'm very grateful, they seem to believe me on that. And I can't imagine what it's like not to believe that you have an illness, sitting in front of a doctor who wants to give you medicine and nobody else saying that, I can help you in another way. We have to believe our patients. We have to understand that our patients are going through those experiences. We may not agree on the cause, we may not agree on the symptom etiology, but they are going through what they're going through. And that validation is essential. And our installation of hope must include this idea that we can help you even though we don't agree. And this is a kind of a throwaway comment. When my patients come to see me with schizophrenia, I always ask the question, whose idea was it to come and see me today? And invariably, it was not my patient. I know very few patients with schizophrenia who say, I need to go see a doctor today. In the last 6 months, the two people who did come to me like that both said, I came to you because I was hoping you will end my life because I'm suffering so much. It was a terrible reason to come, but fortunately, they're both doing well and no longer consider death as an outcome that they want. I'm going to ignore this. We'll go ahead because I said I will do this in 5 minutes and it's a short bit. So the next bit is what gives me hope in the treatment of schizophrenia. Schizophrenia is an extraordinarily serious illness. I know of very few illnesses that can change someone's life, their hope, their trajectory, their ambitions, their achievements, their relationships, and their peace of mind. But there is hope. We have a lot of treatments. They're not perfect. And I'm going to talk about the bits that give me hope. A lot of those things we are doing here in Bangalore, and I wanted to focus on that. There's a lot of fantastic international research going on. There's hope of a cure. There's all of that. But I don't want to talk about other countries. I want to talk about what we're doing in our region, in our city, in our services, so that we can talk about the real hope there is for our patients. So our clinical psychology internships, this year, we're probably going to have about 300 psychologies, bachelor's and master students come to us, and they will all have exposure to schizophrenia. And this is a real article of faith for me, that I think the biopsychosocial model is an excellent one, provided we make enough room for each of those biological, psychological, and social. And with my psychology students, I think it is essential they see brain disorders like schizophrenia, where trauma is not the root of it, nor is some cognitive distortion that can be easily treated. On the right, you'll see we had an MOU earlier this year with Christ University, which is the largest psychology faculty in the country. And we're really hoping that with this collaboration, we should be able to teach as many psychologists as we can what schizophrenia might actually be and what the role of psychotherapy and psychological function there is, so that it's seen as a multidisciplinary thing. I trained well before I finished my psychiatry in neurology and neuropsychiatry, and I trained in the national units for brain injury in Scotland. The top left and the bottom are two national brain units in Scotland where I trained. Gentleman in the middle is Dr. Brian Pentland, a wonderful neurologist who taught me in the old-fashioned way how to hold a knee hammer and how to use it. Bottom right is Professor Alan Carson, very famous neuropsychiatrist and teacher in neuropsychiatry. And of course, Dr. Kalyan Sundar, who continues to be my teacher and colleague, and from whom I've learned a lot. And I think, based on all my training, I think one of the big mistakes we're doing in psychiatry is to call schizophrenia a long-term condition or a disorder without actually saying something terrible has happened to the brain that the patient had no control over and will spend the rest of their life coping with. This is no less serious than my patient's brain injury in Scotland. I see some of my patients, the expectations of the parents saying, Dr. Saab, ठीक नहीं हुआ है, अभी तक वो पहले जो कर रहा था वो नहीं कर पा रहा है, क्योंकि उनको he has a hugely serious illness. We should stop talking about the cure. We should stop talking about things that say, oh, no, everything will be fine. Sab theek ho jayega. Ye hum bol nahi sakte. We have to see. And for those people who are not getting fully well, we should not insult them by saying, oh, no, that's because you're not trying hard enough. In fact, the families will treat many of my patients as if they were lazy because of the negative symptoms. It's not laziness. It's an inability. Many of my patients with schizophrenia are as unable as my brain injury patients at actually doing the things they once did so effortlessly. So my recommendation really is that we do consider whether we should change the paradigm of schizophrenia, not to a long-term psychological condition, although it is long-term, but the consequences of a brain injury that is catastrophic at the outset and continues to be troublesome for the rest of the patient's life. One of the many things we're trying to do is understand the Indian family. One of the big differences between my working in the UK and working in India is that this is not my saying, I think others have said this better than me. We don't treat individuals in India, we treat families. On the left, with the big group of people, that's in Germany earlier this year, or late last year. I'd gone there with Dr. Tuhina Ganguly, who's a sociologist and social anthropologist, to talk about the outcomes of schizophrenia, why outcomes might be better than India. To our right in the blue suit is a very famous psychiatrist, Professor Norman Sartorius. On the right-hand side, you'll see Dr. Reddy, GNN Reddy, an extraordinary neurosurgeon who did psychiatry before he did neurosurgery, and his wife was also a professor of microbiology at NIMHANS. Dr. Reddy was instrumental in changing the All India Mental Health Institute to NIMHANS, a great leader, but he set up the family units in NIMHANS. That's why his photograph is here. He's the one who set up the units that said families can come and live with their loved ones in NIMHANS, and we will help treat the patients, but the families will do the cooking and the cleaning and the looking after. It's an extraordinarily prescient way to treat people and really compassionate for a neurosurgeon. Dr. Reddy is an extraordinarily compassionate man. Doesn't strike you like the neurosurgeons you'll see on television. But understanding the Indian family is part of what we're doing to try and see what can we do better, because some of our models of care come from across the seas and don't really sit well in the way we treat patients in India. This is something really exciting. Some of the photographs I've used without saying to my colleagues, I'm going to show you a photograph in a talk. So I apologize if you're on the talk and you see a photograph, I'll apologize to you later. But we're doing something really exciting. We've been planning this for a long time. The lady in the center is Dr. Rajani Parthsarathy, who is Deputy Director for Mental Health, Department of Child and Family Welfare. She is a very dynamic psychiatrist who's really turned Karnataka's mental health and possibly India's mental health care around. She was instrumental in setting up Manasa. Many of you people know it. But we're collaborating, and on the bottom of the slide are Dr. Nilanjan Datta, our new psychiatrist, Amoga, who's a research psychologist, Etha, who's a psychologist, and counseling psychologist and internship coordinator. We're doing a project with the state government where we are collaborating with the free ambulance system, with the police and the state government. And we're going to do a pilot that says, if you have a psychiatric crisis at home and your patient needs to go to hospital, we will come with our clinical team, the government ambulance, and the government police, if necessary, in the event of severe agitation, distress, or violence, and we will safely convey you to a psychiatric hospital. The pilot will be to Manasa, but then beyond that, and this is with the blessings of the Principal Health Secretary of Karnataka. Very early days yet, gone out yet, and we're about to do that. But I am going to talk about projects that haven't yet got off the ground, but are close to it, just so that, because it offers me a lot of hope, because one of the big problems that we have, particularly in Karnataka, is if you have a psychotic patient at home who does not want to go to hospital, from K.N. Guruswamy Charitable Trust. The person who's given us the money doesn't want to be named, but we're very grateful. And the Netkalapa family. And we're going to do a project. We've already started a project, and it's the first module is in depression. And I want you to imagine this. If you come to us with a condition, in depression, for example, we're going to offer you a course that you can enter, your family can enter, and anyone else you want to can enter the course and learn all that we know about depression. And it's going to be expanded to schizophrenia very soon. But imagine if you're going to come and you have schizophrenia, we will spend 3 months teaching you all that we know about it. We will also spend that much time teaching your family. Anyone is welcome. Our psychology interns are welcome. Anyone can come. It'll be free to use, and we will teach you all that we know. And what we're hoping is that we're going to build the capacity in the community that way, where we teach interested family members what is schizophrenia, what is it like to have it, what can we do to help those who have it, and how do we manage the rest of it. This is a model that we have stolen from diabetes. Across the world, diabetics are becoming expert in their own conditions. Why can't we have people with schizophrenia who are an expert in their own condition? Insight might get in the way, but let's try. But I'm very grateful to the KNG Trust. Dr. Tara needs no introduction, and we met her recently last year in their 40th anniversary in Chennai. They have an amazing first episode psychosis early intervention service where you treat someone as soon as possible so that you limit the damage that Dr. KS talks about. And she has been very generous. She and Dr. Grishma have been very generous to say, we will help you emulate some of our work in Bangalore. And it's not yet, it's something that we're still in discussion with. And I'm very excited that we're hoping that when we see people with early schizophrenia and early psychosis, we can do a much better job at giving them the treatments they need, the help that they need earlier than we ever did. Thank you to Dr. Tara of SCARF. This is very new. The idea that you can do scans and genetics to see if you can help your patient decide which medicine might be best for them. And also once we start treatment, particularly with the left-hand side MRI, by the way, that's an Indian MRI that's not yet come out to the market. I'm very excited. That's 2 people in India have set up an MRI system. It might be much cheaper than the old one. But if we were to do serial MRIs to see what's happening to people's brains, we think, and we're not 100% sure of this, but a group of us are working on this idea that if we were to do more careful assessments right from the outset, we will be able to suggest medicines for patients that are best suited for them in the way that is happening in cancer, the way it's happening in other conditions. And very exciting, very early work. And I think there is a lot of hope this way. There is more where this is coming from. This is something that I am very interested by. There is such a thing as a digital phenotype. This has been established in mood disorders. If you wear a smart ring or a smartwatch, your smartwatch and your smart ring actually learns a lot about you. And many of my patients and their families ask me and say, is there a way we can lapse before it happens? And we think that perhaps by using some of the, what is called actigraphy, heart rate, and social media patterns, that we might be able to suggest to families and patients, more importantly, we think you might be becoming ill again. Do you want to go seek help?
It is already a co-host now.
Okay.
Okay.
Just checking, Deepshika, can you hear me? Okay, great. This is Chetana, which is the daycare center at Richmond Fellowship Society. And right in the center are more people from SCARF. And you'll see Dr. Lakshmi, Dr. Shvashni, and they came and taught us a fantastic therapy, CCT, compensatory cognitive therapy. And a whole group of us learned over 2 days what we can do for patients who have severe cognitive symptoms as part of their schizophrenia. And it's actually pretty extraordinary. The therapy wasn't very complex. We think it holds hope. And so we think that maybe the way to go about this is if you spot symptoms early, cognitive symptoms, negative symptoms, positive symptoms, that we do the biopsychosocial. We don't wait for the disability to come out and hit you or for you to come and complain before we start doing remedial work. And cognitive compensatory therapy or compensatory cognitive therapy has a lot of hope. It's been trialed and it's being researched in SCARF. And we think we're going to be able to use it in Bangalore with good success. In Manasa, we already had between 12 and 13 patients going through it with good effect. RFS has started too. We have lots of patients we can help, and it's quite exciting for us. How do you manage side effects? Side effects are sometimes what we would call the rate-limiting step of treating schizophrenia. You can't chuck medicine in people, change their dopamine receptors, and expect nothing bad to happen to them. whole lot of bad things happen. Ignore the details of the slide. I'm not going to read out that stuff to you. Every part of the body. And this is just clozapine, by the way, people. This is just clozapine. Clozapine, if I could take away the Ganesha in our hospital and put a statue to something, it would be to clozapine and lithium. Clozapine is an extraordinary drug that works beautifully in treatment-resistant schizophrenia, but it can also cause tremendous harm to the human body. We need to take this much more seriously. My poor patients were saying, I don't believe I have an illness and your medicine is giving me side effects. It must feel doubly cruel to go through that, where you're going through a terrible experience of believing you're being persecuted. And you have this doctor and a group of healthcare professionals who seem nice, but force you to take medication. That must be doubly cruel. I can only imagine what it's like because I've seen so many patients, and it does feel harsh from our end as well. What we're hoping to do is to do a better surveillance system that says, if we start you on medication, we're going to do a lot of tests before we start them, and we're going to do a lot of tests during your treatment, and we will do lots of checklists asking you about symptoms every time we see you, so that you don't have to come to us and say, like a patient came to me the day before and said, since you started me on that medicine, I've had no erections at all, and I've not been able to orgasm. And so we immediately checked his prolactin, but it also reminded me to say, why did he have to tell me? Why did I not check his prolactin? And maybe that's what we're going to do. It'll add a little cost to care, but I think for the majority of my patients, for us to take the side effects as seriously as we take the symptoms will help my patients also feel I'm not going to be left to cope with my side effects on my own. These are other people's successes. My colleagues in Richmond Fellowship are working very hard. We've had clients trained at Mitti Cafe, and we've had clients who got their first jobs, and I'm so proud of them. Craftizen comes. I don't know if you have Craftizen up north, but Craftizen is this amazing social enterprise that helps us build things, do things, make diyas for Holi, for Deepavali, make agarbattis, and they bring us the machines, they provide us the training, and when our clients work on it, the money that they make, we are able to give back to the clients, so the clients feel I have an income. It's not a huge amount, but it's the best social enterprise I've seen in a long time. I am very grateful to both Mitti Cafe and Craftizen for helping our clients. And if you've not heard of them, Google them. They're brilliant people. Left field. And Deepshika and Aditya, you can stop me at any point. I think I'm still at the 28-minute mark by my standards, but if you want to stop me, please go ahead. There's lots of other things. I don't have to talk about them. This is just a quick point to say, we're working on a plan to say, if I have a patient who is on a long-term injectable, who needs once a month injections, but isn't taking them, do they have to wait to become sick before they're brought to hospital and then we start it? Or could we find a way to go to their home, give them that injection? It's a short compulsory injection that may take no more than 1 hour of their time, but it is less restrictive than waiting for them to become ill, completely ill, unmanageably ill, before we go out in an ambulance, bring them back, readmit them to hospital, go through the whole system again. There are ways that we must consider. How do we make our care much less restrictive than it is? We should not be allowing too many of our patients to fall well below acceptable standards before we pick them up. But this is a human rights issue, and I don't think this is an easy task. So we're going to work with family groups to deal with this. I just wanted to big up Sumana Trust. Sumana Trust has come closer than almost any family groups I have seen to answering this question, who and what after me? And the other question that Mamta ji from Sumana Trust asked, can we also do rehabilitation at home? So for the first time, we're collaborating with this amazing group of family members and carers to see they're building a community living space near Bangalore. And we are working with them to see, can we provide a daycare or a assertive outreach program into your own homes from in where you're living? So we'll have a team station near them. But more importantly, they have, I think, a very good idea. They've created a trust of family members and carers so that if the carers are no longer able to look after their loved ones, there will be a relay race. There will be other carers that will be stepping in. You really should explore this. You should check out Sambandh Trust. I think they have something that a lot of people have been looking for, an idea that I think has legs. And we're very excited to work with Sambandh Trust. We from Richmond Fellowship Society, very excited to work with them. So my family's asked me, is there anywhere like my child can go, my son can go, that looks like a school or a college? Yes, there's a daycare facility. This is in Chetana, and Chetana is now free to people to use. We have 60 people going there 6 days a week. We've got some government assistance. This year we had some really generous money from Mrs. Sudhamurthy, and so we've been able to subsidize the care there to the point that it is free to everyone to use 12 months a year, 6 days a week. And we're very proud of it. We can stop here, Deepshika, because otherwise we'll go on. I just wanted to mention the new project that Dr. Lata is involved in, the idea of why are all our patients with schizophrenia celibate and single? That's my question. I don't think there is a need for them to be celibate and single. I think there is something in the way we're providing care that is inhibiting relationships. And we're all going to work together, clients, us, families, to see, can we support, even promote connection and relationships? Don't know. We're doing research. Really exciting stuff. Why does frozen feces from a person with schizophrenia, when transplanted into lab mice and rats, why does it cause a schizophrenia-like syndrome? There is something in the microbiome that offers us real hope, and hopefully we can look into it. Okay, that's me. I'm going to stop sharing. That was the end of my spiel. I hope of some interest to you. I'm a geek. I'm really interested in these things, and I tend to go on, but I'll shut up now and happy to take any questions.
Thank you, Dr. Aditya. It is really a very informative session.
Dr. Aditya, thank you so much. Fantastic session. पर आपने सारा ही सेशन आपका अंग्रेजी में था और आपकी स्पीड थोड़ी 60 किलोमीटर पर आवर, तो ये बहुत अच्छी बात है कि हमने रिकॉर्ड कर लिया और दीपशिखा ने बड़ा स्ट्रिक्टली आपने उनकी इंस्ट्रक्शंस दीपशिखा को टीचर मान के थोड़ी ज्यादा सीरियसली ले ली. अगर आप इसको स्लो जाते, बट द ब्यूटीफुल पार्ट इज दैट इट विल बी रिकॉर्डेड एंड पीपल विल बी एबल टू सी इट, बिकॉज आई हैव ऑलरेडी सीन सो मेनी चैट बॉक्स में कि बहुत अच्छी प्रेजेंटेशन है, रिकॉर्डिंग हम बाद में देखेंगे. तो कुछ चीजें मेरे लिए भी डाइजेस्ट करना, थोड़ी स्पीड ज्यादा थी, तो हम उसको रिकॉर्डिंग बाद में देख के धीरे धीरे डाइजेस्ट करेंगे. पर मेरा पहला ही प्रश्न, आई एम सो इम्प्रेस्ड एवरी टाइम आई हियर यू, आई एम सो इम्प्रेस्ड. आप कौन सा च्यवनप्राश खाते हैं? मतलब इतना टाइम और एनर्जी इतनी सब चीजों के लिए कैसे आती है आप में?
It's ADHD. I have ADHD. I get interested in all sorts of things. सब जो भी shiny चीजें होते हैं ना, उनके जाते हैं. One of my ADHD patients says, I like shiny things. I'm like that too. हर रोज कोई नया आइडिया आता है, कोई आते हैं कोलैबोरेशन के लिए. But in fairness, a lot of the stuff that I've talked about is not mine. It is a collaborative effort. They're not all my ideas. As I get older, I'm more excited by collaboration because there are lots of us who can work together. Ownership matters less to me now than it used to when I was young. And बहुत सारे लोग हैं इस फील्ड में जो बहुत अच्छे काम कर रहे हैं. And I think हम साथ हाथ मिलाकर साथ में हाथ काम करें, so we'll get much. Particularly, I think there is a real dearth of the voice of the person with mental illness.
Yes.
There are improving family advocacy groups, बहुत सारे हैं.
Yes.
बहुत अच्छे हैं. But the person with mental illness in India, it feels to me, जो हमारा जो Mental Health Care Act वो सब है, it is still very paternalistic. We are taking people's human rights and depriving them quite. So we must be able to go further. But I must say, to find family members, then to find people with mental illness who will work with us. And I think we should, as part of the advocacy movement, I think listen more clearly to patient voices, people with mental illness.
Thank you so much, Dr. Aditya. Another aspect of yours is, I mean, even though you are a very sort of renowned professional, you are thoroughly grounded and quite self-effacing. So I'm sure, yes, collaborations, yes, but you're also a very thorough professional. Deepshikha, what we could request everyone is to type their questions in the question box, and then slowly we can also open it up to people. You can unmute and people can ask themselves. पर अगर कुछ लोग टाइप भी कर सके ना चैट बॉक्स में या क्वेश्चंस में, तो फिर मैं और दीपशिखा आपके क्वेश्चंस रखेंगे. एक क्वेश्चन डॉक्टर आदित्य जो ऑलरेडी जब आपका प्रेजेंटेशन शुरू भी नहीं हुई थी तभी उन्होंने क्वेश्चन आ गया था कि शादी कर सकते हैं क्या. And I know that this is a huge question in the Indian scenario. I have seen so many disasters and then so much of, thinking around it in the Indian family setup. So this question and the sort of difficulties around it, if you could shed some light.
Shadi Beshak. I think I am a second generation psychiatrist. In my father's time, हम ना कहते थे. हम कहते थे कि नहीं, I think अकेले रहना better है. But आजकल हम सोचते हैं कि देखो, whoever wants to get married, they should have the right, the opportunity. उनको चाहिए तो करना चाहिए. But ये परसों एक पेशेंट आए थे फैमिली कि बोले, this usual problem, डॉक्टर साहब हम क्या कहें दूसरे को जब हम लड़की देखने के लिए जाते हैं, उनको क्या कहें, क्योंकि आप दवाई दे रहे हैं, मेरे बेटे तो ठीक हो गया, पर आप बोल रहे हैं कि दवाई छोड़ नहीं सकते. अब कैसे दवाई दें? Every family wants to tell the truth, but almost every family lies at the time of the wedding. ये जो catfishing जो कहते हैं, this is a different form of catfishing. But I have a lot of sympathy for both parties. I have met a lot of people who said, मुझे कोई भी जानकारी नहीं थी शादी से पहले कि ऐसा है बीमारी, और I have been left, it is a life sentence, now I have to look after this person. If I had known, I would have said no. So दोनों तरह की importance है. And I think my own feeling, and I could be wrong, I'm using a word that I don't let my interns use, which is feeling. We should have thoughts rather than feelings. But this idea that maybe we should move away from marriage as the ultimate goal for all. That perhaps what is needed is a disruption of society. All my young students are on Tinder, on Bumble, and on Hinge. Why are not my patients with schizophrenia? Why could we not get together and ask Tinder and Bumble and Hinge, say, can we have a safe space for people with severe mental illness so that we can manage with things like vulnerability so that exploitation risk is low? But if people want to meet up, to connect, just to have friendships and have intimacy, why does marriage have to be the vehicle of that? What is happening in schizophrenia is we're still stuck on this idea कि सिर्फ शादी से ये सब मिलने वाला है. They're getting all the things that used to be only available in marriage. बाहर मिल रहा है, crowdsourcing. And maybe my schizophrenia should be allowed to say, you see, I managed a very large rehab service in the UK that was nothing like Richmond Fellowship Bank. It was not as good, the outcomes were not as good, but we had a lot of money. On a regular basis, my patients were meeting each other, falling in love, having sex, doing all of those things that you'd expect other people to do, despite being on large dose antipsychotics, all of those things. Why in our rehab units is nobody falling in love, nobody having sex? In fact, I raised this point in Imans at a conference recently, and a very senior psychiatrist said to me, you're wrong. Some years ago in my rehab service, a couple got married. Two log, that doesn't make a trend. That is an exception. I'm so glad they met, fell in love and got married. But are we, families finding it difficult? We need to make a safe space, maybe create, I don't know, speed dating for those with severe mental illness. I don't know. It doesn't have to be severe mental illness. Why does somebody with severe mental illness have to match up with somebody else with severe mental illness? In fact, that is a question I get asked a lot. Dr. साहब, आप कोई किसी को जानते हैं जो इनके प्रॉब्लम्स जैसे उनको भी है, ताकि वो साथ में एक दूसरे की मदद करें. I don't know. I just know that doctors are the wrong people to provide this solution. I think doctors in all of these years, we have failed. प्यार, मोहब्बत, relationship, connection, डॉक्टर की बस से बाहर है. बट हाँ, किसी को शादी करनी है जरूर, बेशक. She's
Dr. Aditya, one of the person has asked that he has schizophrenia and also a heart condition. He smoke a lot in spite of his condition. Can you please suggest something that he can help to quit smoking?
Sure. Good question. Nicotine is among the most addictive substances known to man, and particularly schizophrenia में there is something biological that जो लोग जिनको schizophrenia है वो nicotine receptor stimulation ढूंढते हैं, not only for reducing negative symptoms and cognitive symptoms, but also to reduce the medicine levels. अगर आप हर रोज सिगरेट पी रहे हैं तो इसके मतलब है जो एंटीसाइकोटिक अगर आप ले रहे हैं उसका ब्लड लेवल जरा कम होता है एंड आपको साइड इफेक्ट्स कम महसूस होता है. इसलिए बहुत सारे मेरे पेशेंट्स स्किज़ोफ्रेनिया के साथ, उनको पता नहीं, बट स्किज़ोफ्रेनिया के साथ nicotine addiction is very common. How do we treat it? With difficulty. There are nicotine replacement. Across the world, we suggest that most people need some nicotine replacement. But बहुत सारे मेरे patients कहते हैं कि डॉक्टर साहब मैंने chewing gum try किया, patch try किया, उससे कोई help नहीं हुआ है. And varenicline, there is a medicine called varenicline. Unfortunately, India में वो withdraw हो गया है, वो available नहीं है, वो जो tablet है, which reduces craving. But there are in almost every city, there is smoking cessation groups, hospital-based treatments. You don't have to get admitted, but there are therapy and social intervention systems. They can be very powerful. The most important thing is, since you're asking, you're already a good chance of achieving it. Because you're already saying, I don't want to smoke, I want some help. That in itself is enormous. And I think with that level of motivation, you should be able to get help. Look for smoking cessation groups around you and see if you can find some. Sometimes if there's a local mental health service, they will be able to provide that for you. And it might be worth doing that.
One more question is here, that what are the acceptable standards of allowing a patient to be picked up for hospital, as mentioned by you towards the end?
The standards are very low at the moment, but our standards should be much higher. And I think recently we had this where Dr. Datta, who was a really good doctor who's working with us now, had gone to someone's home. And I made him say, I know he was not going to say this to the family. When the family came to meet us before the home visit, I'd asked Dr. Datta to say to him, we will do our best to bring your loved one. वो बहुत एंग्जाइटी आ गया वो फैमिली में कि ये इसका मतलब क्या है कि you will do your best. आप गारंटी क्यों नहीं दे रहे? और हमने कहा, because we had to say, look, we will come, we will assess the situation. If it is safe for the individual, your family, and the people coming in to visit, then we will bring them. Because you can't use violence against the severely ill, and you can't use exceptional violence. What you have to do is be proportional. This is a patient who is ill. They may be neglecting their health. They may be not eating and drinking properly. They may be not looking after themselves. Occasionally, they are violent to others, but mostly they are not. Most of my patients with schizophrenia are not at all violent. Occasionally, there are risks of self-harm, of suicide. And then we may need to be much more assertive in going out and managing it. The standards are many. One is the grounds for compulsory treatment must be met. Patient ko bimari hai ki nahi. That has to be established quite early. Second, is there clearly a risk? Sometimes some of my patients with schizophrenia have delusions and hallucinations, but they're not hurting anyone else. They're looking after themselves. They're managing their lives. They're going about their day. Then we cannot say there is such risk that we must treat them against their will and we go to their house and pull them out and bring them to hospital. You have to manage it proportionally. Third, do they have the capacity to make these decisions? Can they think through the facts and say, do I need treatment? Do I not? By definition, those who need compulsory treatment do not have the capacity to make decisions. One of my patients recently said, no, I'm 100% sure that my neighbors are going to kill me. Nothing you say will change my mind. And nothing we said did change his mind. And he certainly did not have the capacity to make his decisions. Finally, bringing them to hospital has to be the least restrictive option. If you can manage at home, if you can give medicine at home, then you shouldn't really be bringing to hospital. But I will have one caveat. Covert treatment, in my view, causes more problems than it solves. जो पेशेंट को पता नहीं है कि वो दवाई ले रहे हैं, जिनके खाने में पीने में आप दवाई दे रहे हैं, that is not a great solution to that problem. Because side effect, who is going to take responsibility for the side effects? अगर मैं कोई पेशेंट को नहीं देखा, उसको अगर मैंने दवाई दे दिया, even if my intention is good, will it not cause side effects? And if I cannot see the patients, who is responsible for the side effects that that poor patient is going to get? They may feel better, it may reduce the symptoms, but it is not a good long-term solution. So covert treatment at home is not a good alternative to compulsory treatment. I would prefer my patient to be told, I know you don't want treatment, but we're still going to treat you, so that you know that you're having treatment and you have a right to a refuse. You can go and appeal to the legal system to say, ye compulsory assisted treatment, which nahi chahiye. At least you have those rights. But not telling the patient and giving them secret medicine deprives them of all human rights. And I am not a fan of that. ठीक है जी.
डॉक्टर आदित्य, कहीं आपकी बातों में, एंड यू नो, आप इंग्लैंड रहे हैं इतने साल, सो आई थिंक lot of it has to do with the cultural milieu that we are in. So for instance, the family support system is very strong in India, not so much in the UK. अब वो UK individualistic या western individualistic culture है, so just as it is so easy for young adults to, you know, dating sites and have casual affairs or relationships, and that sort of marriage is not the end goal in life. So I think that translates that difficulty. So we have our cultural advantages and disadvantages. ऐसे ही मेंटल हेल्थ केयर एक्ट का मैं कुछ प्रोफेशनल से भी सुनता हूँ और फैमिली से तो बहुत बार सुनता हूँ. अब जैसे पुष्पांजलि ट्रस्ट तो मेंटल हेल्थ एडवोकेसी पे ही काम कर रही है, और मेंटल हेल्थ केयर एक्ट पढ़ता हूँ, फैमिली से बात होती है, हमारे फैमिली ग्रुप्स हैं. So one of the criticisms is कि इंडियन मेंटल हेल्थ केयर एक्ट ये ज्यादा इन्होंने यूके का ही कॉपी कर लिया है, एंड पर्सन विद मेंटल इलनेस के राइट्स की बात हो रही है, फैमिली के क्या राइट्स हैं, और इफ दिस पर्सन इज बीइंग वायलेंट तो ना पुलिस मदद करने को आती है, ना हम जबरदस्ती हॉस्पिटल ले जा सकते हैं. So it's as if the family's rights have gone for a toss. Your thoughts on this, please?
No, I think this is not a question. I think what you have said is absolutely correct. बहुत सारे family members मुझे यही सवाल पूछे हैं कि हमारा rights का क्या? Because you are focused on the patient as an individual. You are focused on preserving their liberty. But what about our right to a safe, secure home? What if I'm being terrorized in my own home? What if I am worrying so much that I have to lock my own door? Why is no one caring about me? I think this is a really good point. I think, to be fair to those Drs. Patare and co who cut and paste from international mental health acts, they did it with no cooperation from Indian Psychiatric Society. They had to work very hard to put this in. I agree that it was not road tested properly. In fact, the legislation went through so quickly that I think the Indian Psychiatric Society was also surprised, saying, "ये इस देश में कैसे इतने सारे frameworks की ज़रूरत है." In fact, most states in India don't have a proper mental health review board system. Karnataka is ahead of the curve, and we have a good mental health review board. But even that, whenever we email them saying we have a patient, we're getting a response back on the email saying inbox is full. But ये जो आप बोल रहे हैं, ये बिल्कुल सही है कि family representation is poor, especially in India, because the big difference between India and the countries I've worked in are that in India, the responsibility for a mentally ill person is the families. ये family का responsibility बनता है. हमारा government जो है, कोई भी नहीं बोल रहे कि देखो ये हमारा responsibility है. In the UK, the welfare of a severely mentally ill person falls to the government and all of its machinery, including the National Health Service. In fact, both my patients were admitted for 6 months and the family never came and visited. No money was exchanged, but they didn't come. They felt this is your job, you have to look after. We can't. Whereas in India, every single thing is paid for by the family. Even if it is subsidized, it still falls to the family. I think you're absolutely right. The next iteration and the revision of the Act must include voices from families to say the threshold for compulsory care and assisted home care is too high. You're making us suffer much longer than we need to. But in fairness to the government, they're aware of this. I spoke to the Principal Health Secretary of Karnataka recently. He phoned me at 9:30 in the evening to talk about this ambulance program. They want to do this. The police want to do this, but they need help because no one arm of the government is adequately resourced to fix the problem. And I think public voices, advocacy groups will need to support, and we need to have a public-private partnership. The government wants to help. Certainly in Karnataka, we have a very compassionate government with respect to mental health. Particularly, I think, led by Dr. Rajani and Go, they're doing an amazing job. I think families do need a greater say in this.
Thank you so much, Dr. Aditya. You're so articulate and so balanced. You put it in perspective. Thank you so much. Just shifting gears, 2-3 questions थे कि पेशेंट्स मेडिसिन खाना बंद कर देते हैं कि साइड इफेक्ट्स बहुत ज्यादा होते हैं, तो उनको दोबारा मोटिवेट कैसे करें? पहली बार तो फिर भी मान गए, दूसरी बार द रेजिस्टेंस इज मच मोर. And then there's a similar question on something you touched on, not similar, but related to medicine, कि ये जो नया MRI medicine और personalized medicine की आप बात कर रहे हैं, where are we now and what hope does it offer? What is the kind of realistic time estimate?
Okay, first question first. I think it's a very important thing. That's why the principle in schizophrenia is to give as little medicine as possible, as low a dose as possible, if possible. Unfortunately, India में क्या हो रहा है? मेरे patients मेरे पास जब आते हैं, they've already been waiting for months and years because no one knew this was an illness. They'll have gone मंदिर गए होंगे, दरगाह गए होंगे, वास्तु का change किए होंगे, hand is full of those diabetes before they come to me. And that by that time, it's so ill that we have to use larger doses of medicine. But if possible, as few medicines as possible, as low a dose as possible, and a very close eye on side effects, we must assure our patients that our treatment, especially if it is compulsory, doesn't mean that they have to put up with all the side effects. Clozapine, that wonderful drug, you can put on between 50 and 20 kgs in a year on that medicine. Now, we have a duty of care to say that's not okay. We must fight, maybe use all the new anti-diabetics. So we were thinking, should we be using Monjaro? Should we be using semaglutide for my patients? We're already using metformin to reduce weight. It's so unfair to say to them, eat healthy and exercise more. If they could eat healthy and exercise more, मेरे पास आते नहीं, दवाई भी लेते. These are patients with particular executive dysfunction that makes it very difficult कि वो अगर वो चाहे भी कुछ करने के लिए बहुत मुश्किल है. The obstacles to doing something is so great, it is unfair for us to say, आपको exercise करना है, आपको diet करना है. आसान है तो कर देते, but बहुत मुश्किल है. We must do more to look out for side effects, seek them out and treat them, so that we can also assure the patient we are not going to put you through additional suffering as if it doesn't matter. In the old days, erectile dysfunction, sexual dysfunction, my patients who didn't have periods, we would say, anyway, they're not going to get married, they're not going to have children, it doesn't matter. But it matters to them. It matters to my patient that he has an erection, even if he does not have a sexual partner, because it matters to us. We must be better. And I think we must be careful that we don't impinge too many human rights in an effort to get to our goal of medication. And I agree with you. If there are serious side effects, बहुत सारे मेरे patients ना, they get afraid. They say, एक बार मैंने लिया था और ये हो गया था, मैं कभी नहीं लूँगा. Then it becomes extra hard to treat them. But there is a way. There are ways for us to do it. The second question is the tougher one. We're going to hopefully in the next 6 to 12 months start that program with the MRIs and the gene mapping. But we are not in a position to say that from day one that will be helpful to you. We're going to learn a lot about it. So I don't want to suggest it as a clinical advance. We think it will be a clinical advance. Don't take my word for it. We're going to collect a lot of data before those data actually turn around and help individual patients. So I don't want to make it sound like it's improvement of care from day one, but we think we need to assess for a lot more on day one before we start treating these patients. Schizophrenia requires more attention, more assertive and aggressive care, and everything that we can offer, we should offer on day one. We should not wait for symptoms to come, for disability to be awakened, side effects to be seen for a whole year before we start treating them.
Thank you so much, Dr. Aditya. Deepshikha, आपका कोई question? Meanwhile, Dr. Aditya, I would also request you to shed some light on the rehabilitation and recovery journey. Now, there's a lot of variation in that and some success stories, but and it's not a straight path.
Yeah.
So, kuch rehab or recovery pe, if you could shed some light, please.
I think we're fortunate in Bangalore to have so many rehab facilities. But you were at, I think many of you were at Dr. Kalyan Sundaram's excellent talk, where he talked about the different kinds of recovery and rehabilitation. And we're fortunate because he was instrumental in helping setting it up, that if you've learned from Dr. Sharada Menon, you'll realize that she said rehabilitation should start on day one. पहले दिन से शुरू करना चाहिए rehabilitation. और ये जो चीज है सिर्फ कहने के लिए बात नहीं है. हम पॉजिटिव सिम्टम्स को बहुत मेजर कर लेते हैं, बट ये जरूरी है कि हम नेगेटिव सिम्टम्स और कॉग्निटिव सिम्टम्स शुरू में ही मेजर करें और बार बार मेजर करें, ताकि वो रिहेबिलिटेशन जर्नी जो है पहले दिन से शुरू, ताकि when we're seeing biopsychosocial शुरू में होना चाहिए. As soon as the positive symptoms are even partially better, we should be looking, has there been damage to their cognitive function? Has there been damage to their independence? Can we do daycare? See, cost is sometimes a problem. What we have learned in Richmond Fellowship is you cannot make money from daycare. You will lose lots of money. But we also learned that there are lots of good people, including the government, who are willing to support you to say, Aap kar do, we are not expecting you to make a profit. We like what you're doing, go ahead and do it. So we will do this as long as we can, keep rehabilitation. The more difficult point I want us to make is this, that you heard my brain injury analogy. Many patients with brain injury are also like this. Sometimes you can do all the therapy and the rehabilitation you can, but you're not going to achieve improvement in some functions. It would be important before rehabilitation for us to say, we're going to try and maximize your brain and social function, but we may fail. And it's important we don't put that back onto the family and the patient say, aapne koshish nahi ki. Koshish kiye honge aur na bhi kiye honge. But the treatment may have failed. We as medical professionals, clinicians must continue to seek more effective rehabilitation. Rehabilitation is tough. Those of you who are interested in science, if you do a literature review on what is the effectiveness of rehabilitation, you'll realize that the evidence for rehabilitation in schizophrenia is very little. What does it actually do for patients? And we know that it reduces homelessness. We know that it increases lifespan, because if you're following someone up, you're going to make sure they get their ECGs and their heart function and everything else, so that they don't die 15 to 20 years early like they used to. You can have better outcomes. But beyond that, with respect to social outcomes, we must do much. We work, our vice president Richmond Fellowship is Professor Rajan Gurukar, extraordinary academic, who says, ये जो social research आप कर रहे हैं ना, it is worthless. It doesn't teach us anything. You have to do good quality research to say, try this rehab approach. Does it work for the individual? Does it not? We must do more research. We must try new approaches, whether that's dance movement or yoga or supported employment, whether it is newer forms of medication, whether it is reducing side effects, whether it is incentivizing patients to take treatment and do stuff, giving more freedoms, providing social connectedness. I don't know. We have to work together. I don't know where the next solution is going to come. It might even come from the microbiome. It may be that the bacteria in our gut will tell us how to treat schizophrenia. But I think rehabilitation is a really important thing. There are for-profit rehab facilities that are not really rehab. There are not-for-profit rehab facilities that I am much more fond of. I'm biased. including Medical Pastoral Association Bangalore, which is the oldest in our area, and Richmond Fellowship ourselves. We have several branches. Your Pushpanjali Trust, the work that Sambandh is doing, this is essential work. The holy grail is, how do we help people who are in their own homes, maybe in tier 2, tier 3, tier 4 cities, even in tier 1 cities? How do we provide rehabilitation there in an affordable, meaningful manner? That I have not been able to fix or solve. That because we cannot expect all these patients and their families to come to a brick and mortar facility far away, pay for that coming, lose their livelihood. We have to have better solutions. I think it may be that if ever we get closer to prevention and an early cure, that's what's going to happen, in the same way that AIDS has completely changed since we have treatments for HIV. Thank you.
Dr. Aditya, Dr. Aditya, one of the attendees really asking about that as AI is growing, is there any gadget, is there any smartwatch who can help to detect the relapse?
That is our hope. That is exactly our hope, that there is a lot of AI, and I don't think we have to invent anything. My hope is, and see, I don't generally have any brand new ideas. What I have is, okay, you can do that there, why can't you do it here? And it is this, that if we allow a phone and provide it, data safety, etc., that if we allow a watch to understand your behavior, your movement, your thoughts, your emotions, and maybe even keep an eye on your social media use, we should be able to spot relapse. We should be better able to understand wellness. See, a lot of my patients with schizophrenia continue to have symptoms that are underground. And because we don't know about them, some of my patients will come to me when they're ill, and I said, "Are you hearing your voices again?" They said, "What do you mean again? 10 साल से मैं सुन रहा हूँ डॉक्टर, आप क्या बोल रहे हो?" हर बार मैंने आपसे पूछा कि आप वॉइसेस सुन रहे हैं और आप ना बोले, हाँ क्यों बोलूं आपको, इसलिए my problem. We must need to better understand the wellness that our patients have with schizophrenia and their watches. The AI is less AI than machine learning. I know the word AI is overused. It doesn't require artificial intelligence. It just requires a watch and a phone to learn what is that person's digital signature. If that changes, can it change during illness? How do we understand it? Can it provide early warning to the individual and their family and their doctor? Yes, that's what we're hoping.
Thank you so much, Dr. Aditya. पीछे एक question था कि a basic question, but since a lot of people may be hearing schizophrenia for the first time, कि थोड़ा सा biosociopsycho model समझाइए क्या होता है?
I think ये कभी-कभी बोलने की बात हो जाता है, but it's important that schizophrenia is an illness, a disease that affects your body, your mind, and your life. In the same way, the assessments and the treatments must be of your body, your whole body, not just your brain, including your thyroid function, your calcium, your antibodies. Very rarely schizophrenia is misdiagnosed when there is antibodies against your body. Psychological function. Who are you normally? What is your personality like? What is your attachment style? What is the way you cope with problems? And on top of that, when you've had your illness, what is your behavior like? The psychological assessment of your, of you. And thirdly, the social, which is, I think, wo add-on ho jata hai, social. But I find the social much harder because it is the social in which all illness is manifested. If I had schizophrenia, it is my relationships that are damaged. It is my self-worth that is damaged. It is my ability to work, earn a living, get self-confidence. It is the social that is the most important and the least easy to fix and understand. That's why I think as doctors and mental health professionals, we had a plan. I feel a little disappointed in saying this. We were going to work with a PhD student in demands on this issue, which is how do you put the social into biopsychosocial from day one in schizophrenia? It might not happen, but I haven't lost interest. I'm hoping we can still do it. That when my patient with psychosis comes, a social worker is there from day one to assess and assist them. because the social is where the illness is wholly manifest. It is in the family, and it is the social that is the presenting complaint. Doctor, he's not talking to anyone. Doctor, he sits in his room on his own. Doctor, even when he talks to us, he doesn't say very much. Doctor, he seems to be talking to himself. Doctor, he's not looking after himself, and me and my wife are having to do more. We're trying to wake him up, and he gets very angry with us. It is the social that is in our discussion. Very quickly, the doctor then says, oh, okay, there's this symptom, that symptom. Yes, but the social is still the central. So the biopsychosocial is not just a phrase. We have to adopt it, embrace it, and implement it in schizophrenia so that we limit the social disability that really destroys my patients' lives. In my head, I see it as a train track. You're going down one train track. When you have schizophrenia, you start going away from your peers. At 18, 19, 20, your friends are going this way, you're going this way. And I can see my patient going further and further away from their age-matched controls and peers. And I'm thinking, what can I do to bring them back? And eventually, me, their family, and maybe the patient eventually says, I give up. I'm never going to be there. And maybe it's partly our problem that we expect them to still go down this train track. Maybe we need to be much more compassionate and say, so what if you don't go down that train track? Let's find another one. Why do we have to go on a train track at all? But this is a tough society to live in. India does not have a lot of social benefits. The government and society we don't look after each other that easily. Families have to work very hard. And I remember I asked this question, somebody asked this question of Dr. K.S., who pays for rehabilitation? Aditya Vikram very quickly entered and he said, it should be everyone, the government, the society, families, CSR, all of us. And I think that may be the way to go.
Wow. In addition to being an excellent speaker and a professional, you also have a very sharp memory. So yes, I was going to say कि ये सारों का, in fact, this was going to be my next question to you कि आपको क्या लगता है कि स्किज़ोफ्रेनिया की ट्रीटमेंट और रिहैबिलिटेशन रिकवरी में सोसाइटी का क्या रोल हो और गवर्नमेंट का क्या रोल हो?
अगर सोसाइटी और गवर्नमेंट से पैसे नहीं आएगा ना, then कोई फायदा नहीं है. And I think it will never work. I think there's a very famous professor of NIMHANS who calls Richmond Fellowship Society Rich Man Fellowship Society because we charge what it costs us. For example, in Asha, our halfway home, it's costing us approximately 38,000 a month to look after someone and provide good quality care. It is expensive. Most families cannot afford this. We must find another way. If we can afford BrahMos missiles, if we can afford Rafale aircraft, forgive me, I'm not saying these are more important than that, perhaps I am, then we can afford to look after those of us who have had an unusual brain injury called schizophrenia. These are not people who asked for this illness. 1 in 100 of us have it. And perhaps the funding that needs to come to society, too much funding is going to the hospitals, too little to the community. And maybe, I think the answer will lie, the disruption will come from advocacy groups such as yours, because mental health care is merrily progressing as if we are meeting the needs for our loved ones. The treatment gap that Dr. Nirmala of Amend Face Me talks about is still not bridged. In fact, Dr. Alex Cohen, we met him in Germany, said that the treatment gap is not solved by the time when the patient goes and sees a doctor. Many doctors fail the patient in their first visit. That sometimes we get a patient, but we are unable to help them, and we have lost the opportunity to help them. So I don't think the answer is with doctors. I think there are rehabilitation facilities that doctors can be part of, but the doctoring is actually quite small. So I'm hoping family groups will get so fed up with the low quality of rehab care to say, पहाड़ में जाए, हम खुद ही चला जाते, we will build one. गांव में, छोटे-छोटे गांव में. There are some good experiences going on. Dr. Manoj Kumar of Mental Health Action Trust in Kerala is very clear that the future is not in hospitals and in brick and mortar, that हर गांव में जिनके जो बीमारी है, गांव वाले की जिम्मेदारी पड़ता है कि वो उनका देखभाल करे, उनके लिए जो दवाएं हैं, दुआ है, खाना है, वो दे. And I think that may be the future, that we become more compassionate as a society and say, ये करना चाहिए. जितना पैसे हम मंदिर में दे रहे हैं, अगर किसी गरीब को देते हैं, that I think we can do. But please look up Dr. Manoj Kumar's work in Mental Health Action Trust. He's doing amazing work, and I think we can all learn from him.
थैंक यू सो मच डॉक्टर आदित्य. इफ आई मे जस्ट बिल्ड ऑन दैट, और ये आपने जिक्र पहले भी किया था, मेरे को लगता है कि इंडिया में इतनी डाइवर्सिटी है ना, सो वी नीड नॉट गेट फिक्सेटेड ऑन वन मॉडल एंड रादर द सॉर्ट ऑफ इट्स लाइक लेट अ मिलियन फ्लावर्स ब्लूम. तो जैसे रिचमंड फेलोशिप, डॉक्टर कल्याण सुंदरम्स एनर्जी एंड पैशन, एंड नाउ यू आर गोइंग टू टेक दिस फॉरवर्ड, यू नो दैट्स वन ब्यूटिफुल मॉडल. वी ऑल लुक अप टू इट. ऐसे ही एक फैमिली ग्रुप कुछ शुरू करेंगे, हो सकता है सोशल वर्कर्स मिलके और स्पेशल एजुकेटर्स, साइको सोशल वर्कर्स मिलके. सो लेट अ मिलियन फ्लावर्स ब्लूम. कुछ सरकारी फैसिलिटीज होंगी गवर्नमेंट की, कुछ प्राइवेट की, कुछ पब्लिक प्राइवेट पार्टनरशिप. I think it's very hard to say that this is the model of rehab or recovery. So in that sense, we have to be open to that. Let a million flowers bloom. Sambandh एक model follow कर रहा है, and they've been very successful in the peri-urban areas of Gurgaon. So, but what works in Gurgaon peri-urban areas may not work in Tamil Nadu and may not work in Gujarat. So using the local resources, but at the same time, the government and the citizens being involved. So that's sort of what I had in mind. And the second quick point is कि ये जो आपने 38,000 बोला, mind you, this is when Dr. Kalyan Sundaram and you and Dr. Lata Hemchand, with all your passion and energy and commitment, don't charge. Imagine Dr. Kalyan Sundaram and you charge, this would have been 50,000, 60,000. So ये 38 भी तब है when it's people stalwarts like Dr. Kalyan Sundaram, Dr. Lata Hemchand and yourself, just because of your commitment and passion, don't take a penny for the RFS work. So yes, it costs, but what I हमारी सारी जिंदगी वो पैसे पे और cost पे, in the end it is like what kind of society we want to live in. Now, it's about providing care. If it costs, it costs. But at the same time, it's also providing jobs. So much of youth unemployment, और इंडिया में साइकेट्रिक सोशल वर्कर्स कितने हैं? 9,000 साइकेट्रिस्ट हैं, साइकेट्रिक सोशल वर्कर्स 1,000 से कम है, उनको भी नौकरी नहीं मिलती. So psychiatric social workers will get jobs, social workers will get job. So in the end, I think the larger question is not about costs and economy, and unfortunately, we are a hyper-capitalist society the world over. Eventually, it is like what kind of society you want to live in. So if it's a caring society, in the end, you will end up providing jobs to young people, social workers, counselors, vocational instructors, psychosocial workers.
Fair point. Thank you.
दीपशिखा, आपका कोई क्वेश्चन?
डॉक्टर आदित्य, संबंध एक मॉडल फॉलो करता है जो बेसिकली जो लॉन्ग टर्म की हम बात कर रहे हैं, ग्रुप होम के टर्म्स में, जिसमें हम लोग बेसिकली क्या करते हैं कि हमने एक सोसाइटी में फ्लैट है जिसमें 2 लोग अभी रहते हैं जो हमारे ट्रस्टीज के ही मेंबर्स हैं, ट्रस्टीज के ही लव्ड वंस हैं. वो अभी रहते हैं और उनको सपोर्ट मिलता है हमारे कम्युनिटी इंटीग्रेशन सेंटर से. बट दे आर लिविंग like a family. It's not a rehabilitation center where psychiatrist is there, nurse is there and providing a support a long-term support or a daycare facility. It is a home for them, and we are supporting from our CIC integration center. But still, when families comes to us, is there still they like the model, they like they like that कैसे लोगों में क्वालिटी ऑफ चेंज में इम्प्रूव आ रहा है. बट स्टिल दे हैव अ डाउट कि हमारे जो लव्ड वन है वो कहीं बाहर चले गए तो कहीं से जो वो डर, एक स्टिग्मा एसोसिएट है. लोग वो क्वालिटी ऑफ लाइफ जीना चाहते हैं, अपने लव्ड वंस को देना चाहते हैं, बट रिस्क भी नहीं, रिस्क टेकिंग बिहेवियर नहीं लेना चाहते हैं. And we are also, we believe that people who have a severe mental illness can lead a normal and fulfilling life. So we are providing we are providing these services and trying to see how this can be fit into our culture. Can you just, I just wanted to know from your side that do you think that this kind of facilities, I mean, we were experimenting and still we seen the change, we see the changes, but still we are, we are struggling between the rehabilitation model, taking somebody to and taking somebody from their home and fit into the rehabilitation center and give the long term support. Why we are not talking a recovery? I mean, a place like people can live, like a friendly environment, like we all are living together, like a family. I just wanted to know your reflection in this.
I think your point is right, but क्या हो रहा है ना, in my Dr. Ganguly and I were doing this paper on Indian families, and my theory, and I think partly hers, is this, that the benefits that the Indian family gives, वो इंडियन फैमिली का जो बेनिफिट है पेशेंट के लिए, उनका देखभाल करेंगे, डॉक्टर के पास ले जाएंगे, दवा के पैसे देंगे, उसके बाद फॉलोअप ले जाएंगे, all of those benefits come at a price of autonomy. ये सब करते हैं, बट इसका मतलब ये है कि आप जो चाहते हैं वो नहीं कर पाते. If you need to go out and you want to have sex with someone that day, then your family might say, ये क्या कर रहे हो? नहीं, आप रह रहो कर. Some of my patients are locked in quietly into their rooms, into their homes, house arrest, वो सब है, पैसे की नहीं होता. And I'm not blaming the families, because I know what the families go through. Because as I get older, I realize that whenever I sit in judgment of someone, invariably I realize I can't, because on both sides, there is some very compelling facts that a patient at the moment in Manasa is about to be discharged. Their family is very involved. But I've realized that if they weren't involved, this poor patient would be in severe harm's way through reckless behavior, risk-taking, very vulnerable patient. And I'm sitting here thinking, is there such a thing as a right to illness? Patient बोल रहा है मुझे कि मुझे छोड़ दो, मुझे कोई बीमारी नहीं है, अगर बीमारी हो भी आपकी जरूरत नहीं है, दवाई ना दो मुझे, just leave me and I won't trouble anyone else. The problem is the patient is not troubling other people, but the patient is going through some terrible experiences because of their illness, and they're putting themselves in harm's way. Family, should they leave them to do this thing, or should they protect them? But I agree with you that the future is not the rehab model that our Richmond Fellowship Society jo hai. I don't think it is a scalable model. Whoever can afford it, it'll keep going. But it is not the future for India. That I think the final solution, I don't want to say final solution, it's a terrible word. Ignore it, please let me take it back. But in the end, we're going to achieve something closer to what you're doing, which is in the community, closer to the home. Can people live in a way that is comfortable to them? One of the downsides of rehab facilities is that we may be dislocating people forever. Some of my patients are saying to me, Dr. Saab, ye mera ghar ho gaya hai. Main yahi khush hu. And I'm sitting there thinking, I'm very happy that you're happy here because we have a therapeutic community. I'm so glad you're saying this is home. But in the back of my mind, there's another question. Kya hum inke ghar se lekar yahan jo le aaye, did we help them or did we separate them from their family? The family is also happy कि देखो ये इनका देखभाल अच्छे कर रहे हैं, आप यही रह जाओ, हम पैसे देंगे. But is that what we were meant to do? Were we not also meant to be saying, आप वापस चले जाओ? And many of my patients are now saying, Nene, please don't say that to me. I'm so much happier here. I have friends, I have connections. I think the answer must be that in the first place, we don't dislocate people so far. Manoj Kumar from MHAT may have a point. He doesn't like the word schizophrenia. And Aditya Vikram was saying the theme of this year's thing is re-examining the label. Manoj Kumar does not like labels starting with SCH. I don't mind. I think schizophrenia should be called schizophrenia. But I think he has a point when he says, they don't all need to be taken to another शहर, कोई बाहर दूर से कहीं अस्पताल में लगा के वहां जबरदस्ती इलाज करे. क्या हम उनके गांव में इलाज नहीं कर सकते? क्या है जो हम गांव में नहीं कर सकते? Why Vikram Patel and Co and Manoj Kumar have shown task shifting. Why does everybody have to be a psychologist, a nurse, a doctor? Could you not teach a 10th pass person how to manage some of these problems? Yes, you can. Could you not teach a school teacher how to do some of this stuff? Yes, you can. And I think that may be the Anganwadi system, all of that India already has. We may need to add a bit of last mile connectivity. But India has a great public health system, at least in design. The implementation, state to state, gaon se gaon. But in theory, India's public health system can be used to add value here. Karnataka mein kuch ho raha hai ye sab. It's not enough. There is still a treatment gap. But maybe that is the future, that NGOs and us, those of us working in the NGO space, will work alongside the government, use those facilities to the maximum for our clients, and then add a little extra and get funding just for the extra, not for the whole shooting match. That's at least my fantasy.
Thank you so much. Yes, Doctor.
Thank you so much.
Yes, Aditya.
Thank you so much, Dr. Aditya. We are so very grateful for your talk, for your illuminating us with all the different aspects of schizophrenia and rehabilitation. And every time I hear you, my respect for you grows. You are a thorough professional and a fantastic speaker. And just your command over so many different aspects, psychosocial, rehab, community, and the fact that you've been abroad, you're able to, put things in perspective, be very grounded, not have the solution, be very open, be very humble. Every time I hear you, I just admire you even more. So from the bottom of our heart, we thank you so much for taking the time out and talking to all of us. We will be sharing the recording with people. In fact, I need to hear it 2 or 3 times so that I understand everything you said. मेरे को लगता है आपके पास ज्ञान इतना ज्यादा है, उसको 30 मिनट में समेटना मुश्किल हो रहा था. तो वो अब जैसे मैं भी बूढ़ा हो रहा हूं, तो वो 60 किलोमीटर की रफ्तार जो आपकी थी वो मेरे से पकड़ी नहीं गई. तो मुझे लगता है कुछ और लोगों से भी नहीं पकड़ी गई. तो ऑलरेडी 15-20 कमेंट्स हैं कि रिकॉर्डिंग शेयर कीजिए. तो दीपशिखा, आपसे रिक्वेस्ट है, रिकॉर्डिंग मेरे से भी शेयर कीजिएगा. मेरे एंड पे थोड़े वाईफाई इश्यूज थे. और अगली बार हम डॉक्टर आदित्य को फिर बुलाएंगे विद द एक्सप्लिसिट इंस्ट्रक्शन के 30 किलोमीटर पर आवर की रफ्तार से ज्यादा नहीं जाना. हमारे पास बहुत समय है. डॉक्टर आदित्य, आप इससे अंदाजा लगा सकते हैं, हम 120 के ऊपर गए थे और अभी भी 86 पार्टिसिपेंट्स हैं व्हेन वी क्रॉस्ड आवर टाइम लिमिट वेल ओवर हाफ एन आवर. So that's the interest people have had. I have never had such a huge audience for the webinar, and certainly not towards the fag end. People tire out. And there are still questions in the chat box that we've been unable to take. So my apologies to our guests and audience. आप अगर questions हमें लिख के भेजेंगे, तो we will try and put them across to Dr. Aditya. But still better, we will try and organize this very soon. We don't have to wait till next year, Schizophrenia Day. We would request Dr. Aditya, and the lovely person that he is, I'm sure he'll agree to do a talk for us a few months from now. So thank you so much, Dr. Aditya. Thank you from the bottom of our heart.
Very happy to be invited. Thank you very much. But I also have a request. Would you all please put your minds together to see how do we get more PMI representation? How do we get representation for people with schizophrenia? Those voices will tell us something very difficult, and we may even hear unpleasant truths, but it's essential for us to hear them. Because without their voices, then the work we're doing adhura to reh jayega. And I think we cannot help people without their cooperation and collaboration endlessly. But please do give yourself some thought, because you have better access to this than we have. And I was to say to you, we are, and those people like me are learning as much from you as you say you're learning from me, because I learn every day from advocacy groups, from patients' families. They teach me all that I know. And I think if we work better together, then it's truly a partnership. Varna kya hoga, it is just a kind of, it's a thing that looks good, but isn't. I think advocacy groups should be a part of healthcare so that they're no longer on the outside. And they should always be skeptical of the healthcare people. I would be too. But let's see. But if you can get users, service users, people with mental illness, whatever your preferred term is, people with the illness, lived experience, their voices are absolutely essential. Maybe we can have a meet at some point with their voices, because you are hoping that somebody will talk today. And I'm hoping to hear that too. I've had some moving, in our clinics, we hear some amazing stories. If we could put them together, that would be an extraordinary thing. That I would love to be a part of.
Thank you so much. We'll certainly work on it. It has taken us so much effort to get the families out of their shells, and even more effort to get the persons out of their shell. मैं बड़ी बार जोक करता हूं कि सरकारी अफसरों से काम कराना फिर भी आसान है, फैमिलीज को उनके शेल से निकालना एंड पर्सन्स विद मेंटल इलनेस को उनके शेल से निकालना, इट्स लाइक द मोस्ट डिफिकल्ट. बट आई हैवंट गिवन अप. I'm on it. And thank you so much. We will look for more collaborative effort, more collaborative exercise. And I haven't given up. We will get more persons on board as well. I'm hoping Deepshikha is trying too. And next time around, we will.
Thank you both.
Thank you so much, Dr. Aditya. Thanks from the bottom of our heart.
Thank you, Dr. Aditya. Thank you so much. It's really a very informative and wonderful discussion.
Thank you, Deepshikha.